Gonna need a bigger boat. Where's it from? Come on. George, thank you. You guys go to the movies, that's good. I was worried about that. Okay, why do I say that? Here's Jasmine's symptoms. She has this unrelenting head pain. Now here's the thing, she told me as part of the history, and it's very important, these histories are critical to take, because even though I have a lot of forms that you guys fill out, I badger you with questions because sometimes you leave things out. Jasmine had five spinal cord stimulated surgical procedures. Placement, 3 revisions due to complication, and then finally a removal. Quite a lot to have done. Here's Jasmine's back. I outlined the scars from the spinal cord stimulators, surgeries that she's had, and I drew the squiggly lines in to represent the wires that go up there. So she tells me, the only time I get relief from these pounding headaches is if I lay flat. If I lay flat, I get some relief. As soon as I sit up or stand up, I get these pounding headaches. And when she said that to me, that's why I get these epiphanies. And I said, wait a minute. When you lay flat, you get relief, but when you sit up or stand up, your head starts to pound. She says, yes, and you've had spinal cord stimulator procedures, 5 of them? Yes. I said, anybody ever work you up for a cerebral spinal fluid leak? Okay, anybody here ever have a CSF leak that had to be worked on? Go ahead.
Wouldn't do that, but from something else.
Okay, so watch. Okay, nobody ever worked her up for a CSF leak. Okay, you got to think of this. She's had all of these puncture procedures done, and these were done by different doctors in different locations. It wasn't like the same guy going on the same thing. Okay, the treatment for this is an epidural blood patch. This is another relatively easy outpatient procedure that you can have done. Nobody said to her, wait a minute, you've got postural headaches that are pounding away, and you have, excuse me, all these surgical procedures done, maybe there's a leak. The treatment epidural blood patch, and here's the thing that's very important to know. You treat and consider an epidural blood patch based on symptoms. You don't necessarily have to confirm the leak. And I'll show you why. Okay? All pain can be traced to its source. So Jasmine is being considered for a postural provoked headaches, and we're considering that she might have a leak somewhere. So we got to look at the head. So she does have a CT of her brain with IV contrast. That IV contrast is iodine-based. CTs are iodine. That's Jasmine getting ready to go into the CT machine, and I sit with the technician. And the reason you see these pictures, this is what I do with my patients. I'm not saying other people have to do this, but any of my CRPS patients that I order imaging for, I go to those procedures. I'm there because I sit with the technician while they're doing the acquisition to make sure we get it right the first time. Okay, then I can sit with the neuroradiologist I work with or whoever else I need to get an overread with to see what's going on. So she's going to have a CT of her head, and the reason we're doing that of the brain is because we're looking to see she's had a lot of trauma. Is there any pinhole leak somewhere? It could be through the floor, the roof of the nose, it could be the base of the skull, any place. There could be something up there that's leaking a little bit. When you have that CSF leak, the pressure in of the fluid pressure in the brain of that cerebral spinal fluid drops, and if it drops, it's an agonizing type of pain. Okay, now the other thing she had done is she had multiple MRIs done of the cervical spine, thoracic, and lumbar spine. That's done with MRI, and that is done without contrast. Now let me tell you why. Look at what I have up here. The MRI contrast agent that's used for MRIs is different than the CT. The contrast agent that's used for MRI is called gadolinium. There's multiple versions of it, but this can be very, very toxic to certain patients, certain patient populations. However, it's extremely toxic to patients who already have CRPS. The reason for that is because your immune systems are already dysregulated. Your immune systems are already not functioning properly. So let me ask you, show of hands, who's had an MRI with contrast here? Hands up. Look at this audience. Now, let me ask you a question. Of those who had that done, how many of you remember either getting sick on the table or subsequent to it, feeling either new symptoms or symptoms ramping up? Brain fog, burning pain, bone shocks, anything, skin alterations.
Changes.
Those things?
Some types of changes after many of these procedures.
Right. So they probably tell you, hey, drink a lot of water, you pee it out, and it'll be done. Okay? I'm gonna tell you that's wrong. You don't get rid of this stuff. It stores in the body. Okay? And here's what happens. You can develop a disease in the literature called gadolinium deposition disease. That's when your body really gets sick from the gadolinium that's used in the contrast study. It's called GDD. The true world authority is Dr. Richard Semelka. He's home-based in Chapel Hill. He's an MD radiologist, couple hours from here. I send patients to him all the time when I suspect gadolinium toxicity, which is easy to find out. I'll show you how. And now, why is this relevant to CRPS? Okay, I say all pain can be traced to its source. I call gadolinium deposition disease chemically induced CRPS, because look at the symptoms. Here are your symptoms of gadolinium deposition disease. Here's my CRPS chart. Okay, these are called asymptoms because they're symptoms that are significant to any type of heavy metal poisoning. Okay, so I blue star the overlap. Look at how many symptoms of gadolinium toxicity overlap with CRPS. So I say again, if you've got symptoms that are not responding to treatment or not resolving, and you've had even just one, it doesn't matter. If you've had just one contrast study with gadolinium, you could potentially be toxic to it, and that might be what's keeping you guys lit up. Okay, and the link is that sympathetic disorders disrupt your immune system. The gadolinium basically goes after it and causes further dysfunction. Okay, this is a nasty disease, but it can be treated. It gets treated by getting the gadolinium out of your body, but it has to be done a certain way. The only person to do this, for me at least, because all of you guys, for me, they have no room for error, I send them down to see Dr. Semelka. Okay, and the way I figure out, do you have gadolinium in your body at all, is with 24-hour urine capture. Jasmine said, I never had an MRI with contrast. So if you look at this urinalysis, this is a clip of some of the heavy metals we look for, but she has 0 gadolinium in her body because she never had a contrast study done. So that makes sense, okay? And I'll tell you, the green, yellow, red, that's irrelevant. That means nothing. What's significant is if you've got that in your body, this is what's called unprovoked. When you do a chelation procedure, you're actually gonna grab more of that stuff and pull it out of your body. All those numbers change. Okay, there's a way to confirm this disease. It's very simple. I could spend half a day on this. Okay, but that's not what we're here for. So here's the deal. She had a CAT scan done to look at the bony structures around her brain. She had the MRIs done, but no lumbar puncture procedures were performed to try and isolate this leak in an absolute fashion. You can do more harm than good looking for a pinhole. You start poking holes through the dura, looking for a hole. You're creating a hole to look for a hole. So it makes much more sense to treat it like it's there based on her symptoms. Severe postural headaches is a hallmark for a CSF leak, okay? Now, we could not locate a leak. Nothing was found. That doesn't mean it's not there. It just means we didn't see it. It could be a tiny pinhole, could be anything. So what do? Do we tell you, well, Jasmine, look, you got CRPS. You're a chronic pain patient. Why is my head killing me? It's idiosyncratic and atypical. You know, I don't want to tell you, okay? We don't do that. I don't do that. All pain can be traced to its source. What do we do instead? Here's Jasmine's back again. Now you see I've labeled again the spinal cord stimulated surgical scars. She came to me. We know she has these postural provoked headaches that are indicative of a potential leak. And I said to you, even if you can't locate the leak, treat it like it's there. Okay, here's why. Here's an article, New England Journal of Medicine. Get a little closer to read it. 2021, epidural blood patching is successful in reducing or eliminating symptoms in most patients. It can be done without localizing the leak. You don't have to find the leak to treat it like it's there. Okay, that's number one. This is from 2018 from the Headache Society. And what they say is when it comes to epidural blood patches, they work, but oftentimes you need more than one. Okay, one is not a one and done. And again, an epidural blood patch is a relatively not a low-risk procedure, let's call it that, done by when you have the right doctor doing it. So, Jasmine, that bandage, Jasmine had 2 epidural blood patches done in November and just last month. And here's what happened. Okay, 75% relief of these banging postural headaches that she's had for years and years. 75% reduction. First one relieved a couple of days, pretty good. Second one brought her much more tremendous relief in these pounding headaches. Okay, so all pain can be traced to its source. Don't tell me you're chronic, idiosyncratic, atypical, and all that stuff. You gotta look. You go based on history. Listen to what the patient's saying. There's a famous doctor from the mid-19th century, Walter Siles. Doctors, listen to your patients. They're giving you the diagnosis. Okay, you just gotta think it out. You gotta listen and think it out. Okay, so we did these blood patches and they worked quite well. They've helped her. She's gonna have more of them too. That takes us to chapter 4, sorry. Chapter 4. This one's a little tough for you guys. See if anybody knows the one. Please, sir, might I have some more?
Oh,
Oh man, you guys are good. I was gonna say, Aliva. Remember that? When I got Lisa Brown by the ear and said, "You want more?" I'm glad you guys knew that one. Okay, so Jasmine, we heard about this earlier. She also has POTS. Okay, now I blue highlighted some of the major symptoms of POTS. You guys know about this if you have it. Here's what's so critical to know. Look at the overlap of symptoms with POTS. You actually have POTS listed as a symptom of CRPS and dysautonomia listed as a symptom of CRPS. There's a reason, because 50% of POTS patients are basically sympathetic in nature. The sympathetic nervous system is what's driving the POTS. So of course you're gonna get CRPS with POTS. They're gonna go hand in hand, but here's the deal. The overlap of symptoms of POTS with a, guys, I'm just blanking for a second. The classic signs of a spontaneous intracranial hypotension, that means the pressure in the brain drops. Those symptoms overlap with POTS. And what this article is saying is to do this. If you've got POTS, non-resolving symptoms, consider maybe again there's a leak and then an epidural blood patch comes into play. Okay? Because you might have a way to abate these symptoms if you make an assumption that it might be a leak somewhere. Because the symptoms are so similar on top of the CRPS. Now here's one more part of this puzzle. Hands up, who's got Ehlers-Danlos been diagnosed? Just the one, anybody else? Okay, well, Ehlers-Danlos is a disease of connective tissue. The connective tissue doesn't form properly, doesn't function properly, and that's why they're hypermobile and are more prone to injury, sprains and strains, but also you're more prone to tears. Okay, so Ehlers-Danlos patients tend to have more risk of CSF leaks because that dura, the connective tissue, is more prone to injury and tear. So here's yet another reason. If you have these conditions, this is just one I picked out because it really relates to CRPS, is that can put you on the table for another reason to potentially need the epidural blood patch. Okay, all pain can be traced to its source. Okay, chapter 5, Houston, we have a problem. Thank you. You said Apollo Creed? What? You're so bad. Apollo, how you doing? We have a problem. What's the problem? Not all good. I need some help with you guys. I want a show of hands. How many people here suffer with gastroparesis? A couple of you. Okay, so let me show you something. Jasmine has had this horrible condition for many, many years, and basically it means gastroparesis means paralysis of the stomach. It means your stomach gets food into it, but it won't move it out. It doesn't push it through digestion. When the sympathetics dominate, the parasympathetics are overridden, and you don't get that peristaltic wave that pulls food from your stomach and into your intestine and such. Okay, now here's the thing. There was a relatively new medication out. It's called Motegrity, FDA approved in 2018 to treat chronic idiopathic constipation, and I put this up because I can't say that word, but FDA approved in 2018 to treat chronic constipation, but also approved off-label to treat gastroparesis. Okay, now here's what's interesting. This is just off their website. Look at what this says, that most cases of gastroparesis are considered idiopathic. That's from 2018. Well, I beg to differ. Here's an article from Dr. Schwartzman. He's another true giant in CRPS treatment as a neurologist and researcher and such. This was published in 2012, this article. Beautiful article. It's on my website. You can download it if you want. Every system of the body, every organ of the body, he goes by each one of them and tells you how CRPS affects it and what you can do about it. So look at what he says about gastroparesis. That this is common if you've had CRPS for a couple of years. It's a very common entity and present in almost 90% of all patients have gastroparesis who have CRPS. So it's not an unknown and it's not idiopathic. Okay? That's an easy medication. If you don't know about it, ask your doctors. FDA approved 2018. That's been a big game changer for Jasmine. Inside of 2 or 3 days, it kicked in and she can eat and she's able to, the constipation is overruled. The peristalsis comes back. Okay, we still have some problems here. Jasmine still has this severe stomach pain. Pain that's tricky. She eats or drinks and she gets severe abdominal pain to the point where she'd rather not eat or drink. She can go days without eating or drinking. Okay? And let me just say, again, this medication Motegrity and such, that's prescribed by a gastroenterologist that I work with. And before we did any of this, she had endoscopy, colonoscopy, I work with an excellent gastroenterologist. I'm not doing all, I'm the tip of the sword guiding all these things. I take it upon myself to do that when somebody comes under my care. But I work with excellent GI doctor, multiple pain doctors, whatever I need, I have to do the various procedures you're seeing. Okay, so she has severe pain upon taking in food or drink. And she's had this for years and years. She's told it's stress. You gotta learn to deal with your stress. Okay, anybody here been diagnosed with MALS? Median arterial ligament syndrome, anybody? Nobody. Okay, anybody, but you guys all have, anybody have stomach problems? Now the hands go up the stomach. Okay, but stomach ache, stomach pain, when you eat, you get pain, that kind of stuff. Okay, so that could be the gastroparesis, but also it can be potentially what's called median arterial ligament syndrome. Let me share what that is. Very important to know about. You have the aorta that comes off of your heart, comes straight down attached to your spinal column. When it goes below the diaphragm, you have that ring-shaped ligament. That's the median arterial ligament. And it can be due to trauma. It can be due to medical condition like Ehlers-Danlos, where the connective tissue is just not well formed. And what happens is that ligament will slip. And if it slips down, it'll crimp that celiac artery that you see later. That celiac artery is what's given the main blood supply start to the organs of digestion. So if you can imagine crimping a water hose where you bend it so much that the water can't come out. You drink or eat something, and the body wants blood to come into the stomach to start digestion, and it needs help. But if that artery is crimped, then the blood can't get there, and the body says, wait a minute, if you're doing that, I'm gonna make you hurt. Pain is a sign that something is wrong. When you have something, at least something like this. Hey, so how do you test for this? There are two main tests that you do. One is a blood flow study, it's a Doppler, and the other one is a CT angiogram. They inject iodine, it's a CT, and you light up these vessels, and you can actually see if there's a crimp in there or not. And or you can also measure the blood flow through that artery to see, is there any kind of blockage or any kind of MALS event where there's a constriction that would account for these terrible stomach aches that she's had for so long. Okay, so here's her test results. Negative for MALS. No stenosis, no narrowing, no constriction, no reduced blood flow. Yet, she still has this horrible stomach pain, agonizing. She eats or drinks and she's just in agony, and she says, I'd rather not eat or drink, I'd rather not have the pain and almost and essentially become dehydrated and malnourished than have that pain. If you can imagine how severe, you guys know how painful CRPS is. Imagine it's in your gut so bad that you don't want to eat or drink. Okay, so what do? Should I tell her, well, those tests were negative, Jasmine, you got CRPS, chronic pain. Why do I hurt? Why do I have this if there's no mechanical constriction? Oh, well, that's atypical facial pain, I guess. I don't know. Should we tell her that? Not me. Not on my watch. What do? Okay, severe pain to eating and drinking. Just like I can do a superficial cervical plexus block up here, that I can isolate and account for all types of sympathetic dysfunction to the head, neck, face, and mouth. The doctor that I work with who does this, he can do a diagnostic celiac plexus block. And he's blocking the sympathetic nerve innervation to the organs of digestion. The celiac is the digestive organs. So he performs that block. Now, why does he do it? There's no constriction. Why does he do it? Here's the literature. 2018, I think it is. Clinical response to celiac plexus blocks confirms that the MALS-like event, where you get this pain upon introducing food or liquid into the stomach, is not so much a mechanical constriction as it is a nerve-based issue. Because if you look at what it says here, that more often than not, the issue is going to be a nerve-based issue. It's the sympathetic nerves. Remember, let's call CRPS, remember, it's disease with a mind of its own. So it'll hit you anywhere it wants, as it wants, and when it wants, right? Okay, so in her case, I said to myself, I thought we fixed your jaw joints, and I thought everything else would get better. Then I thought we plugged that leak, CSF leak, and I thought her stomach would calm down. It didn't. So I started to realize, you know what? Your stomach is probably just its own hub. And therefore, that has to be dealt with. Now, we want to make sure. So, what we do is a celiac plexus block. So here's Jasmine's back. We're going to add to it. She had those spinal cord stimulator procedures that really probably created the leaks that she had. She had the epidural blood patch ×2 so far. That helped her. And then those two white bandages are where she had the celiac plexus block done. Okay, and that's done under fluoroscopy with sedation, because it can make sure she still don't want her to feel anything. And here's what happened. She got 100% relief of all those stomach symptoms that have haunted her for years. Her CRPS, is sympathetic, just focused in the celiac plexus. And here's what happens. The celiac plexus is a lot of sympathetic nerves there, and if those sympathetic nerves are dysfunctional, remember, Crips and sympathetics is a disease of vasoconstriction. So these sympathetic nerves are just keeping these blood vessels to the celiac area in constant spasm, so that you just can't get blood flow when it's called for. And that's what's causing it. The proof of it is the block worked. Okay? So that's the simple part of the diagnostics, but here's the problem. We say, okay, you know what? You want to end this thing, let's do an ablation. When I say let's, that's the doctor doing it, when I discuss it with him. And Jasmine would concur. An ablation is basically an electric burn. They're going to just cut that, just burn that nerve as it comes off the spinal cord to end the sensory nerve innervation to the celiac plexus, because that's what's shooting that pain pulse back into the brain. Sensory pain to the brain, all the other stuff comes out. The ablation didn't work. What do? Give up?
It's
Quit?
chronic.
What's that?
It's chronic.
What did you say? Don't make me hook up on you, brother. I see you've been listening. It's good. All right, what do? Go. That takes us to chapter 6. Chapter 6 I call, come on, the enemy deserves no mercy. Where's that from? Who? Come on. Okay, I'll give you a hint. Ready? Karate Kid. The enemy confronts you.